The section head of pediatric emergency medicine and the medical director at the Children's Hospital Emergency Department. Some of you may have met Dr. Grip before in other education sessions through TREK or other pediatric emergency education sessions. She received her medical degree from the Johns Hopkins School of Medicine in 1996 and completed her pediatric residency training at Johns Hopkins as well. Since coming to Winnipeg, she has served as Pediatric Postgraduate Medical Education Co-Director, the Chair of the National Canadian Pediatric Program Directors. She's very active, as you can hear, in medical education here in our province and with the Royal Colleges of Physicians and Surgeons as well. And has served as the Chair of the College of Physicians and Surgeons Child Health Standards Committee, and as well as a Master Faculty for the simulation course, Trauma Resuscitation for Kids, as a course director, both in Canada and globally. So thank you very much, Dr. Grip, for being here today to talk to us about diabetes ketoacidosis in children. And I will hand it over to you.
Wonderful. Thank you, Lisa. I am so glad that all of you are here today. It is a privilege for me to have this opportunity to share with you. At Children's Emergency, and many of you may know this, we see patients not only from the entire province of Manitoba, but also from northwestern Ontario as far as Terrace Bay and the Kivalliq region of Nunavut. So one of our jobs in emergency is to be that tertiary referral center responsible for the care of children throughout our catchment area. And while we may be the ones highly trained specifically in pediatric emergency medicine, we know that the majority of our patients present to you first, to nursing stations, to walk-in clinics, to general hospitals and emergency departments, to EMS providers, and more. You all do an amazing job caring for our young patients. There's much I can learn from you about managing patients with sometimes very few resources and far away from the tertiary centers. So our job is not to tell you what to do, but instead I strongly feel that we as pediatric acute care providers have that responsibility to share our knowledge, and in a collaborative way, we can help each other. So this is the reason we started this educational series. We do welcome feedback, so please do fill out that evaluation form, as well as ideas for future sessions. So our upcoming topics for the remainder of this year include asthma and pediatric trauma. And then in the fall, we'll have sessions on anaphylaxis, bronchiolitis, seizures, and more. So please do let us know what you would like to hear about pediatric acute care. I have no disclosures. My only potential for conflict of interest is that I am the primary author of the CPS statement on pediatric DKA and a co-author of the TREK statement on DKA. So that's not as much of a conflict of interest, but I might be accused of self-promotion. A number of us across North America have worked collectively on these resources, and we've tried as much as possible to make sure they give similar recommendations. And that's also the reason, by the way, that I chose DKA for our first topic. Our objectives today: understand and utilize best management practices for the assessment and management of pediatric illness and injury. We'll review pediatric patient assessment, how DKA is different in adults, and then review management, goals of treatment, and complications that can potentially occur. We'll hopefully become more familiar with using TREK resources to help assess and manage pediatric cases in a general emergency department. And I will say that even in our emergency department, we use TREK resources as well, and we base a lot of our guidelines on TREK. Again, I'm thrilled to see so many of you today and from various fields within medicine. So we have physicians, but we have nurses, and we have paramedics and respiratory therapists. And I think I saw a physiotherapist or two who registered, which is just wonderful. So every one of us comes today with different backgrounds and experiences. So I hope there is something in this presentation for each one of you. We'll start with some references. And of course, I have to and want to include pictures of the TREK guidelines. So we will reference that throughout this talk and future talks as well. These guidelines were revised in early 2023, and then were designed to reflect congruence with the Canadian Pediatric Society statement, as well as the guidelines from the Canadian Pediatric Endocrine Group. There are still a few tiny differences, but we're going to revise those very soon. We're also getting new research information that we'll incorporate. So this is the algorithm that some of you may be already familiar with. And the resources also include pocket cards and order sets and what we affectionately call the BLR, bottom line recommendations. These are all easily available on the TREK website. A few other resources, the Canadian Pediatric Society does have a practice point on their website, which goes into a little bit more depth on why we recommend what we do. WRHA has an evidence-informed practice tool that underpins our children's guidelines. Hopefully that should be available to all of you, and if it isn't, let me know. And then I've mentioned the Canadian Pediatric Endocrine Group, or CPEG, has great information on their website as well. And finally, we've based many of our recommendations in TREK and CPS on the most current literature, including the 2022 guidelines that were recently published by the International Society for Pediatric and Adolescent Diabetes. And I'll mention that the lead author on the guidelines, Nicole Glaser, she and her husband, Nate Cooperman, are amazing researchers in pediatric DKA. And both Nicole and Nate were consultants for the TREK guidelines, and they were reviewers for us. So all of these resources can be accessed with links through the TREK website. But before we go on, I want to talk just for 2 slides about general pediatric assessment. So while children do show up to your hospital, they are likely just a small part of your general emergency population because you see all ages. And the younger patients are, the more they make people nervous, except for us. But we get nervous around older people. So everyone has their strengths, right? And knowledge and experience. So the pediatric assessment triangle, which may be familiar to most of you, is a simple way to assess 3 main characteristics of a pediatric patient. The first one is appearance, tone, interactiveness, consolability, abnormal look, gaze, abnormal speech, cry. We often teach in our residency programs that one of the main goals of the first year of residency is to know when someone's sick versus not sick. And it's different in pediatrics, and it's sometimes more challenging because it changes by age at times, but the basic characteristics are the same. So appearance is the first thing. This is the view from the door. What's your impression when you first look at the child? The second part of the triangle is work of breathing. So abnormal lung sounds, position of the child, leaning forward, tripoding to try to breathe, retractions, flaring, nasal flaring, apnea or gasping. And then finally, circulation to the skin, looking for pallor, looking for mottling, looking for cyanosis. And then you make your assessment, right? If all 3 sides of the triangle are good, then the patient's probably stable. And you have some time. If the work of breathing is abnormal, but the patient appears generally well, then that defines respiratory distress. If the work of breathing is abnormal and the patient does not look well, then you're concerned about pending respiratory failure. If circulation is abnormal and the patient does not look well, you should think about shock. And then at the bottom of the slide, if all sides of the triangle are abnormal, think cardiorespiratory failure. So any questions before we move on? Okay. So let's talk about some background on DKA, getting back to the main topic. So first, epidemiology, right? It's important to know that DKA is common in children. And I will say also that DKA is also seen in adults. So while there are certain things we'll talk about, bronchiolitis, for example, that is exclusive to younger children and not seen in adults. DKA is, of course, seen in adults as well, but it's managed a little differently, and we'll talk about that. So in new onset diabetes, we know that 40% of children present in DKA, and that's how they're diagnosed. We know that having DKA is associated with worse long-term glycemia if you present in DKA as your first presentation. And then for a patient with known diabetes, between 1 and 10 episodes, depending on the study, per 100 patient years. So the average is around 5 to 7. Severe cerebral injury or edema occurs in 1 to 2% of children with DKA. And of those children who have severe cerebral injury, 25% result in death. So let's start with some reviews. The DKA definition, of course, is DKA, D, diabetes, hyperglycemia, serum glucose of greater than 11 millimoles per liter. The K, of course, stands for ketonemia or ketonuria, which means a beta hydroxybutyrate of at least 3 millimoles per liter, or urine ketones, at least 2+, so moderate or large. It's important to note that secondary to changes in the redox potential, that the urine dipstick may actually be falsely negative in some patients. And part of that is because the urine dipstick does not measure all the ketones. It measures acetone and acetoacetate, but does not measure BHB. And early in the course of illness, your BHB actually is the highest ketone. So it's important to check a serum BHB or a bedside BHB if you can. Otherwise, as you know, most of the time the urine is positive. And if the urine's negative and everything else fits with DKA, manages DKA. And finally, A is for acidosis. And that's a venous pH of less than 7.3 or a serum bicarb, which is less than 18. The previous definition was less than 15, so just note that change for those of you who are familiar with managing DKA. Bicarb is a much more reliable indicator as it is not dependent on respiratory compensation. The pH depends on how well or not well they are compensating with increased respiratory rate and tidal volume. For example, someone could have a pH of 7.3 and it's because their PCO2 is 18. They're working really, 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 really hard to do that, but their serum bicarb will be in the boots. Severity of DKA is really defined by the degree of acidosis. Mild DKA, pH 7.2 something, or a bicarb 10 to less than 18. Moderate DKA, pH 7.1 something, or a bicarb 5 to 9. And then severe DKA, pH less than 7.1, or a bicarb less than 5. And it's important to note that the more severe number is used, again, as from our last note, because the pH can be higher than expected. Usually in pure metabolic acidosis, the pH corresponds to bicarb, but again, respiratory compensation can bring up the pH. What this means also is when we're managing DKA, we often see that the pH actually stays relatively the same for the first few hours, even though the patient is getting better. But because the PCO2 and the serum bicarb are slowly increasing, and then the pH starts to improve. Risk factors for DKA include younger age, adolescent patients, and peripubertal patients, so the two extremes in our population. Having had a previous DKA increases your risk for future DKA. Infection, poor glycemic control, social and mental health issues, lower socioeconomic status, and then more difficult or limited access to care. And some of these, of course, can overlap. So we'll start with our first poll. Okay. I've got 3 polls today. So the first poll is, how are you treating pediatric DKA in your hospital? And the poll contains 4 questions, so answer all those questions before you submit, and then we'll show you the answers. It's looking good. We'll give it another 10 seconds or so. Great. Why don't we end the poll and show the results? Okay, so quite a spread. This is really very helpful information. So are you using the Trek guideline? So there's a range. Some people are always using it. Some people are never using it, and perhaps just not knowing that they exist. So hopefully at the end of this talk, you'll go on and take a closer look. Do you give an initial fluid bolus to all patients? Again, kind of a range. And some say always or almost always. And this has changed over the years. So when I've asked this question a few years ago, it was more of a sometimes and rarely. And we'll talk about why that has changed in a good way. Usual choice for IV fluids, most people use normal saline. Some use Ringer's lactate, and that's also been a good change over the years. And how do you calculate the IV fluid rate? And many of you do use the Trek guidelines for that. Okay, so we'll stop sharing and move on. And then, so all those questions, again, we'll talk about in our time together. But before we go on, let's go over some pathophysiology. This we all know or knew at one point in our training, but it's good to review. We'll start at the top right of the slide with where the two X's are. DKA starts, of course, because of an absolute or a relative insulin deficiency. And I put that because that's the difference between type 1 and type 2 diabetes, of course. Type 1 diabetes has an absolute deficiency that they don't make enough insulin. Type 2 diabetes, the insulin can be present but not utilized by the cells. And so it's a relative insulin deficiency. Either way, they can develop hyperglycemia, which then leads to glucosuria, glucose in the urine, which then causes osmotic diuresis. Potassium and phosphate follow sugar out in the urine, and this results in dehydration as fluid follows as well. So while serum glucose is high, the cells are effectively hypoglycemic. And this results in increased levels of counter-regulatory hormones, glucagon, cortisol, catecholamines, growth hormone. These in turn trigger glycogenolysis and gluconeogenesis and lipolysis and all those factors, all those processes the body uses to try to manage to sugar and try to get sugar to the cells. The increased free fatty acids from lipolysis then enter the Krebs cycle and they produce ketone bodies. Of course, we've talked about BHB, and we've talked about acetoacetate and acetone as the primary ones. So all of this causes an anion gap acidosis, so the kidney excretes hydrogen ions. It does exchange for potassium transiently, so the potassium can actually be normal or on the higher side, but eventually potassium excretion along with sugar kind of overwhelms the system, and potassium and phosphate are excreted in the urine. So along the lines of pathophysiology, I should mention briefly just one slide about HHS. Hyperglycemic, hyperosmolar state. Has anyone in the group seen a patient with HHS, either pediatric or adult? Maybe you can just note that in the chat. It's not very common, but it's important to know. Yeah, there's a lot of yeses, more in adults. We're seeing it more in children because it's more common with type 2 diabetes, and we're seeing more type 2 diabetes in children. So those of you who have seen it know that they can present a little differently. We won't talk about that at length, but it's important to know that it exists. Right? So HHS is characterized by more severe volume depletion and more extreme electrolyte derangements. They're not very ketotic or acidotic. The serum glucose is very high, but the venous pH is generally greater than 7.25. Serum bicarb is usually greater than 15. Ketonemia or ketonuria is usually quite low or absent. The serum osmolality, though, is very high, and they usually present with a change in level of consciousness. What's more complicating is that it can be a mixed picture, so they can have HHS and DKA, and they generally require much more fluid than DKA. So the criteria for HHS are listed on our Trek website, as well as the bottom of the algorithm, just to keep in mind, as well as a link to the CPEG website, which has management guidelines for HHS. So one more slide for a quick review. DKA usually presents with the 3 polys, and this is true in kids also, right? Polydipsia, polyphagia, polyuria. They drink a lot, they eat a lot, they pee a lot. They can present with GI symptoms, right? Vomiting, which can be from the ketosis, abdominal pain, and even constipation from severe dehydration. And if we had time, I would tell you about a young person who presented with a chief complaint of constipation and ended up having a pH of 6.8 and was in DKA. Can present with neurologic symptoms, right? Weakness and decreased level of consciousness. And then, of course, Kussmaul breathing and acetone breath as well. So now we'll talk about management. But before we do, any questions about what we've said so far before we move on? Okay. I don't see any hands. Feel free to put questions in the chat and we'll try to answer them as we go along if there's anything. So management, what are the goals of treatment for DKA? So the first goal is rehydration, right? We want to correct the acidosis with hydration and insulin, but hydration is our primary initial focus. We correct the ketosis with insulin, and we correct the hyperosmolality, both by bringing the sugar down, but also hydration. We also, of course, want to correct hyperglycemia, but that's actually less important, right? We talked about hydration, acidosis, ketosis, and then all of that will help bring the sugar down. But bringing the sugar down is not our highest priority. And finally, we do want to monitor for and prevent complications. We now use the term cerebral injury, which is the new term for injury as part of DKA. This includes cerebral edema. But there can be other cerebral injury that is not fulminant edema. We know that increased episodes of DKA are associated with academic and cognitive dysfunction later in life and some development concerns. So we know that there's injury that may be subclinical on presentation. And of course, anticipate those electrolyte abnormalities. So many, if not all of you, see adults with DKA. So it's important to highlight the differences in the treatment of children. One is extra caution with IV fluids. They need fluids. We're going to talk about that more in depth, but they're also more sensitive to fluid shifts and third spacing. We initiate insulin only after 1 hour of IV fluids. We know that early insulin before fluids, before some hydration, is associated with increased risk of cerebral injury. The theory is that children are kind of extra sensitive to osmotic-driven fluid shifts when they're dehydrated. Another theory is the direct effect of insulin on the brain cells. And then we avoid insulin boluses for the same reason, which also increases the risk of cerebral injury. We do replace potassium early and generously. Most of our patients are unlikely to have underlying renal pathology. That's not as true in adults. We avoid sodium bicarbonate. This very much increases the risk of cerebral injury. And in children, the thought is that severe changes in pH can actually cause cellular hypoxia. We want to avoid intubation. This is also very true in adults. There are two groups of people that I never want to intubate. One is DKA and the other is asthma. And those of you who manage sick patients, all of you, we know would agree with me on that. So DKA especially is challenging because those really sick DKAs, their pH is already in the boots and they have very little reserve. In children and in adults, right, you need to maintain that higher minute volume as patients are breathing to try to compensate for their acidosis. And it's really difficult to intubate them and have them survive intubation and also, of course, replicate on a ventilator what a patient can do to make up. And this is more challenging in children because just mechanical ventilation in children is more challenging. So there's been some recent changes in the protocols across the country in North America, and then we'll look at each in more detail. So recent literature has shown increased safety in liberalizing fluids in pediatric DKA. So this all started with wanting to change the fluid bolus. So then we looked at other changes, and by we, this is a combination of both national recommendations as well as local recommendations in Winnipeg and Manitoba. So we now recommend an initial fluid bolus for all patients all pediatric patients in DKA, 10 to 20 mils per kilo over 30 to 60 minutes. And I actually didn't change my notes, but I should. We actually now recommended over 20 minutes. So I'll change my notes for future talks. Ringer's lactate is now an option for initial hourly fluids. We can add potassium to that before we add sugar. Other options would include normal saline. The hourly fluids, it's okay to use hypotonic fluids, but for that initial bolus should be normal saline, Ringer's lactate as quote unquote isotonic, although that's a whole nother talk about IV fluids. Removal of the calculation of IV fluid rate based on percent dehydration. So everyone's based on 10%. We know that even mild DKA is, those patients are likely 5% dehydrated at least. Calculate hourly fluid rate based on Trek guidelines over 36 hours, and then changing to a 2-bag protocol for administering hourly IV fluids. And I hope by the end of this talk, I've convinced all of you to look into a 2-bag protocol for your hospital, and we're happy to share our orders and pathways as well. And we'll also talk briefly about phosphate supplementation and electrolytes. Okay, so speaking of dehydration, we did previously to a few years ago, we did make an assessment on dehydration for kids, a combination of clinical assessment and weight and so forth, and came up with this number based on how dehydrated they were. But how good are we really at assessing this clinically? And the answer is we're not. The global we are not that good. So this is an article from 2012, and it's supported by other literature. There's really quite poor inter-rater variability when assessing hydration status. So this particular study used admission weight and discharge weight to determine initial percent dehydration in retrospect, and looked at other markers and vital signs and so forth. So the only factor that was statistically different was the corrected sodium. They did notice that younger patients were more severely dehydrated, which is interesting, and maybe secondary to more limited free access to fluid or ability to communicate symptoms. But overall, the data supports the idea that most DKA patients are between 7 and 10%. And the conclusion of the study was really that the magnitude of dehydration is not really reflected well by clinical or biochemical parameters. So a big study here. So I've mentioned Nate Cooperman before, as one of the big DKA researchers. This is a study out of North America, mostly US, and it was a landmark article with regard to management of DKA. And it's not the first article on fluids and peds DKA, but one of the biggest. So this one finally seemed to make a difference. This was published in 2018. And the details, I won't belabor the details, but ultimately they compared the amount of fluid, giving fluid fast versus slow, what kind of fluid, normal saline, half normal saline, and overall, the two main outcomes. One is that the higher fluid group tended to get better more quickly. And the most important outcome was that giving a lot of fluid did not increase the rate of cerebral injury. For many years, we've not done that. We've not given enough fluid quickly enough. So before we go on, let's talk about cerebral injury and edema. So new information has really informed these updates in treatment. So when I was in medical school back in the early 90s, we learned about this osmotic theory, and some of you may remember this. And this is based on the idea of increased osmotic pressure in the extracellular space secondary to hyperglycemia. The thought is, of course, increased osmotic pressure from the glucose. The water then rushes out of brain cells to kind of keep it matched. And then the brain cells could create these so-called idiogenic osmoles to maintain the osmotic gradient. And then when we start treatment, then the rapid fluids then goes into the brain cells as the fluid shifts reverse and then causes intracellular swelling of the brain cells. So to support this theory, there was a case series, an uncontrolled, not very well done case series in the 1980s that suggested cerebral edema was more common with greater IV fluids. So for decades, we started to limit fluids in pediatric DKA. And we only bolus them if they were an uncompensated shock. So over the decades, what happened? We saw more acute kidney injury from severe dehydration, but no change in the rate of cerebral injury and edema. So the new theory is that cerebral injury is caused by cerebral hypoperfusion and reperfusion injury. We know this for a number of reasons. One is, CTs and MRIs show subclinical injury. We do see evidence of changes in biochemical markers of injury. It can present before the start of treatment. In fact, many cases of severe cerebral injury and fatal DKA actually present to the ED before any treatment. Risk factors for cerebral injury is more aligned with severity of DKA and not the rate of fluid administration. And untreated DKA shows a pattern of cerebral hypoperfusion on diffusion-weighted imaging. And then cerebral blood flow patterns are more consistent with vasogenic edema, which is more characteristic of, again, ischemia reperfusion. And then finally, there's evidence that hyperglycemia triggers mediators which cause direct neuronal damage. So likely this is a combination of several factors, including vasogenic edema, cytotoxic edema, and perhaps some osmotic changes as well. Okay. So with that as background, we now give more fluid because patients need more fluid. So we do suggest, again, 10 to 20 mils per kilo over 20 minutes. And our guidelines say 10 to 20 here in Winnipeg, and TREK guidelines, which are the newest of all the guidelines, do say 20 mils per kilo over 20 minutes. And so that's what we use more and more. You can repeat boluses if clinically indicated, certainly in patients with uncompensated shock. It's unusual to require more than 40 per kilo, but of course, ABCs do come first. We in Winnipeg and Manitoba recommend bringer's lactate as an alternative to sodium chloride, to normal saline. There's not enough literature to suggest that bringer's lactate is superior, but it certainly is non-inferior, and it's becoming a trend more and more with other resuscitation, including sepsis and trauma. Why might it be better? It has lower sodium and lower chloride, specifically with the aim of preventing or reducing the risk of hyperchloremic metabolic acidosis, which is very common, usually outside of emergency. That's an ICU issue, but we'd like to prevent that. There's some buffer in bringer's lactate, some calcium, and there's some, starting to become some more evidence that it may be superior in resuscitation in general. Ongoing hourly rate. Skip the dehydration calculation, just use their current weight. So ongoing hourly rate, which includes rehydration and maintenance, does not include your initial bolus. Based on the TREK guideline, estimate 10% dehydration, and then we replete that over 36 hours. We recommend bringer's lactate for a bolus, and then when adding after the bolus for ongoing fluids, bringer's lactate with potassium. When the glucose is around 15 to 17, changing to normal saline with added electrolytes and dextrose, and can adjust as needed, and even transition to oral at some point, depending on how quickly the DKA resolves. So it's important here to mention that there can be some variability. So for that initial bolus, again, either bringer's lactate or normal saline. For ongoing fluids, they're both a good choice. And some centers even use half normal saline for ongoing fluids, which is okay. You would never want to use hypertonic saline for the bolus. And as well, some hospitals allow different additives to bringer's lactate. Our hospital doesn't allow us to add sugar plus potassium to bringer's lactate, and so we've switched our protocol to use normal saline once we add sugar. So approximately, all of this is approximately equal to 2 times maintenance fluid rate. And if you can't remember the exact detail, just to get started, just calculate their maintenance and double it, or at least the initial part. Okay. Let's start with do another poll. Okay. And while you're answering that poll, you can also put some questions in the chat about what we've just talked about. So this next poll has 2 questions. Okay. So the first question is, at what serum glucose level do the kidneys begin excreting glucose in the urine, glucosuria? And the second question, which is actually related to this, although it might not seem that way, are you using the 2-bag system in your hospital? Give it another 10 or 15 seconds. Okay, why don't we close the poll and share the results? Oh, excellent. So 49% of you said 12, and then there was a spread. That is great. And two-bag system. Awesome. So 22% of you are using the two-bag system, and 70% of you don't know what it is, but you are eager to learn. I love it. Okay. So we'll stop sharing. So the answer to the glucosuria question is indeed 12. So kudos to you who said 12. So you may recall that in DKA, we historically tried to keep serum glucose between 11 and 15, kind of once we were ongoing in the ongoing fluid phase. So while 13 is still better than 33, it still causes problems because the kidneys are still excreting glucose with ongoing diuresis. So let's talk about the two-bag system and how we could make this better. So in Children's Emergency and other hospitals across North America, we now use a two-bag system for ongoing IV fluids. One bag has normal saline and potassium. The other bag has normal saline and potassium plus D12.5. And we chose D12.5 because we have a pharmacy available and it's easy for them to mix up these bags. Other hospitals only have D10 available. You can certainly use D10. And in our WRHA guidelines, we show you how to mix that as well. We suggest running Ringer's lactate until you need dextrose, but you can order these two bags and they can be just ready to go because it does take a little time to make those. We start the dextrose bag when the serum glucose is down to 15 to 17. And the rates of the two bags are adjusted to maintain a serum glucose 7 to 11. So with the one bag system, we aim for 11 to 15 because it can take, up to 45 minutes to get a new bag. So if you're getting any lower than that, you put in the order, you send it to pharmacy, you get the bag, and then you run the risk of hypoglycemia. But because glucosuria occurs with that serum level around 12 or so, best to give tighter control, right? And the practical advantage of a two-bag system includes the ability to quickly adjust fluids and improve safety, and it decreases the risk of hypoglycemia. So we run both bags simultaneously into one IV access point. So what does the two-bag system look like? You calculate your hourly rate of fluids, which you can all do easily now, and then adjust the rates of each bag with what you want. So for example, if you want D5 and you know the rate, then you've got your multiplication factors. Right? And I'll show you a little bit more what that means in the back of our order form. We actually do all these calculations when the patient arrives into ED. So if you decide that you want D5 or D7.5, you just have to look and order those numbers. Right? So the three numbers to know are A, B, and C: the hourly rate, the rate of the non-dextrose bag, and the rate of the dextrose bag. Okay. As an example, these are our standard orders. We write hourly fluids to provide dextrose of X%, and then we simply write our B number and our C number. So talking about insulin, it's really unchanged from what most of us do. Recommend no insulin bolus, again, no insulin in the first hour of treatment, and recommending that initial regular insulin at 0.1 units per kilogram per hour. The fluid volume, by the way, of insulin is minimal and is not included in our fluid calculations, so don't need to worry about that. If needed, you can decrease the insulin if you're struggling with hypoglycemia and you've maximized your dextrose infusion, but that's unusual. In terms of review of evidence, 0.05 versus 0.1 units per kilo per hour are probably equivalent, but there is, again, a little bit of a trend to faster resolution if you're using the higher insulin as well. And again, it's also safer if you're using the two-bag system. Sodium, of course, you can calculate the corrected true sodium. We know that the measured sodium is lower, what we call a factitious hyponatremia, while the total body sodium can actually be normal or high. But you should really use the corrected sodium to make adjustments to fluid. especially with HHS, I'll just mention, because of the electrolyte derangements as well. I won't go into depth too much with that because we have found it, practically speaking, we use different criteria to adjust our fluids, but it's important to know that you can correct the sodium for your hypoglycemia, and if your corrected sodium is going up or down, that can be an indication of needing more fluid or less fluid. For potassium, levels are usually normal at diagnosis, as we've mentioned in our diagram from earlier, even though the total body potassium is actually depleted. Serum potassium can be low for metabolic acidosis, as well as insulin therapy shifts potassium into the intracellular space. So this is one reason that potassium either can be normal at presentation, but can actually go downhill. We add, in pediatrics, we add potassium to fluids as soon as possible. We do recommend 40 millimoles per liter if there's no history of renal dysfunction. Potassium is less than 5 on our CBG. And even if potassium is, just over 5, but there's been some, urine output anytime in the last few hours. It doesn't have to be in emerge, as long as parents say that, they've peed just before we came. That's enough. That's enough for us. No need to know serum creatinine. No need for potassium bolus, and in some situations, oral potassium might be an option. And finally, with electrolytes, a decrease in phosphate. So similar to potassium, phosphates decrease secondary to osmotic diuresis. As well, insulin also promotes phosphate entry into the cells. This does or can cause a decrease in ATP and 2,3-DPG, which shifts that oxyhemoglobin dissociation curves, which increases the affinity of hemoglobin for oxygen and actually reduces oxygen release in tissues, which are already suffering from lack of glucose and cellular injury. There's some theoretical risks of severe phosphate deficiency, including respiratory and skeletal muscle weakness and reduced cardiac contractility. There's no good evidence that replacement affects outcome in DKA, so we don't replace as a standard of care, but locally we have developed guidelines to replace to avoid severe hypophosphatemia. And we have a separate order guideline set for that. Final slide before we talk about cerebral edema and cerebral injury. I know we have several paramedics in the audience and perhaps other individuals involved in interfacility transports. So while I've summarized some of the key points in management, I just want to quickly highlight some considerations when you're en route to somewhere. So a few thoughts. One is to have your fluid bags ready to go. So hoping to convince you of the 2-bag system. If you have those ready to go, you can switch over very easily and you can adjust en route, even if it's a prolonged time transport to that. I'm not sure from an EMS point of view that's needed, again, because you're really giving that initial bolus and hopefully getting to the hospital by then, but certainly transport's different and can take many hours. Very easy to adjust. Remember what not to do initially. Again, no insulin, no bicarbonate, but just go ahead and be fairly assertive with IV fluids. And then always be alert and prepared to manage increased ICP, hypertonic saline and mannitol, which is a good segue into our final section. Good. Any questions so far? Don't see any. Okay, final poll. So a 3-year-old boy presents as a CTAS-2 with decreased responsiveness, a bedside glucose of 46, and a pH of 7.02. A resident has ordered a dose of insulin, a dose of bicarbonate, and 400 mils of half normal saline. What is the most important risk factor for the development of cerebral injury in DKA? So options, age less than 5 years, hyperglycemia greater than 40, severe acidosis, early insulin, sodium bicarbonate, or hypotonic fluids. Let me give it another 10 seconds. So great. Why don't we close the poll and share those results? Okay. So the results, half of you said insulin before fluid bolus. The runner-up was severe acidosis, and then a scattering of other answers. So the truth is that all are risk factors in the development of cerebral injury. The most important one, as we know now, is the severe acidosis. So it's kind of patient factors, less so than kind of treatment factors, again, because we know that this often presents early on before we even see the patient. So we'll stop sharing now, and we'll close our talk with some points about cerebral injury and cerebral edema before moving to our summary. Okay, of course, this is our most feared complication. And a reminder to all, why are we doing this? Why are we doing all of this, fluid, sodium, and managing this? We want to avoid cerebral injury. And again, I've mentioned before a few times, but it's important to remember that cerebral injury can occur in DKA even before initiation of treatment and can worsen with treatment with evidence of perfusion injury. As a matter of fact, we often anticipate that the kid with more severe DKA will actually go through about an hour of time in our department where they seem to be a little confused. And then they get better, and of course we're alert for signs of increased ICP, but we see this clinically as well. Unfortunately, there really is no other way of getting them better and avoiding some small injury, except to avoid DKA in the first place. So when we teach residents, one of our favorite analogies in pediatrics is that adults dwindle and that children fall off the cliff, right? Children compensate reasonably well until they don't, and then they crash. So why do we care? We know that patients can deteriorate rapidly. Prevention is, of course, best, but we need to monitor for subtle changes, and we know that urgent treatment can make a difference. So we'll go through 3 lists as a reminder of what we already know. So risk factors for cerebral injury specific to DKA, patient factors, right? Severe acidosis, some laboratory evidence of severe dehydration. That includes elevated urea and hematocrit reflecting hemoconcentration. Hypocapnia, so a PCO2 less than 20 or so. New onset diabetes that are often sicker on presentation. A longer duration of symptoms, right, which is more common in new onset diabetes. So there's a bit of overlap there simply because parents haven't received the education in terms of what to look for. Younger age, usually say less than 5 years. There's some inconsistency in the literature, but definitely, certainly less than 2 or 3. My youngest kid with DKA was 18 months. So it doesn't often happen with the really young ones, but certainly that's a risk factor. Treatment factors, again, rapid administration of hypotonic fluids, insulin therapy early, use of sodium bicarbonate, and then failure of corrected sodium to rise during treatment, which can indicate excessive fluids. How does cerebral injury present? Altered level of consciousness, especially after initial improvement. So this can manifest as restlessness, drowsiness, confusion, obtundation, abnormal motor verbal response to pain, headache, particularly if severe or worsening or commencing after treatment onset. In young children, irritability, vomiting, and then some later signs, urinary incontinence, hypertension, which can be diastolic, bradycardia, which is not related to sleep or improved vascular volume, changes in respiratory rate or oxygen desaturation, and cranial nerve palsies. And you'll recognize some of those as being part of Cushing's triad. Finally, management of cerebral injury and edema, place head of bed to 30 degrees, put your head in midline position to maximize venous drainage, isotonic fluids. So if you are center using half normal saline for your regular fluids, your ongoing fluids, change to isotonic. A slight reduction in fluid rate to 75% of initial rate. Osmolar therapy, either hypertonic saline, 5 per kilo, or mannitol, 1 per kilo. The literature does suggest a slight preference for hypertonic saline in the context of DKA. And one theory supporting that is trying to avoid the diuresis, which can accompany mannitol. And then, of course, urgent consult with critical care. Important to note that head CT is not urgently needed and should not delay treatment. And finally, let's talk about monitoring and disposition. CPEG, by the way, has some great guidelines for ongoing management of DKA if you are admitting these patients. And for those of you who work in hospitals outside of a tertiary pediatric center, you have a decision to make whether you keep the patient or send them to a larger center. So really, ongoing treatment of moderate or severe pediatric DKA is most appropriate in centers who have access to specialized pediatric intensive care. Mild DKA and some cases of moderate DKA may be appropriately managed in peripheral hospitals, again, with available expertise, including pediatric coverage. Consider PICU consultation with severe DKA, a younger age, and of course, concerns for cerebral injuries. And you can always, always, always phone a friend, particularly a pediatric endocrine or emergency friend in this context. So in summary, DKA is unfortunately common and a major cause of morbidity and mortality despite being preventable. There are management options available to reduce complications if DKA does develop, starting with a fluid bolus of 20 mils per kilo in all patients, to calculate fluids based on weight, to consider using Ringer's lactate until you add potassium with normal saline as an alternative, to consider changing to the 2-bag protocol to allow quick adjustments to glucose concentration, to anticipate and manage electrolyte derangements, and then monitor for signs of cerebral injury and treat appropriately. So I'd like to close with some generative questions for you. And you can put that in the chat or raise your hand. We can have a discussion. So what did you see or hear today that resonated the most? What are you going to take home with you? Which part most intrigues or inspires you? And what will be most important for your hospital to do to make this real? So I'd love to hear your thoughts. And of course, thank you.
Thank you, Karen.
Feel free to raise your hand or put it in the chat, whatever works best.
Yeah, or people can speak up if they want directly, Karen. Yeah.
For sure. I see in the chat, the fluid bolus, that it doesn't cause cerebral edema. Absolutely. And for those of you who've been practicing for a while, know how scared we were of giving that bolus. I've been practicing long enough that I saw the change from giving the bolus to not giving the bolus. And now we come back, and medicine is like that, isn't it? It seems to be a pendulum sometimes. We make decisions based on what we know or what we think we know. And then we have new information. Right? Yeah, more awareness of cerebral injury and edema. Yeah, what we're really trying to prevent. Yeah, good question from Nikki. Is calcium a common treatment in DKA, or is it saved for hyperkalemia with DKA? And the answer is the second. So it's unusual to see true hyperkalemia in DKA. Usually that treatment is insulin, and they already have the hyperglycemia, which of course is part of our hyperkalemia protocol, is sugar in that. So calcium is really used in hyperkalemia to stabilize the heart. And if you were seeing true hyperkalemia, you would use that. Otherwise, in general, routine calcium is not needed. We do follow it with our periodic labs, but not generally needed. It's a great question. Okay. Cerebral edema. Great. We'll be more concerned with severe acidosis, right? And it's good to anticipate those, right? So if they come in, to have that extra vigilance for those complications. Yeah, the smaller centers, again, giving that initial fluid bolus. Yeah, for sure. One thing that you might consider, though, in the transport, because most of these patients are able to come via ground, depending on where they're coming from, is to have some of those fluids set up if possible, and then you just have them ready to go with those calculations. And then in transport, you can, make that decision. You're absolutely right, though. Usually we do tell you to send them away. But other things happen as well, right? There could be weather factors. I know we had a patient who was actually in a nursing station on the Saskatchewan border a number of years ago, and they couldn't get out because of weather, and they didn't have IV insulin. So the global managed a severe DKA at a nursing station in rural Saskatchewan with sub-Q insulin for 2 days, because that's what we had. And the patient did fine. So that is something as well. That's not ideal by any means, but acknowledging the factors that there may be other reasons that we can't get the patient to children's right away. So what age and weight decides if you treat the DKA patient as a pediatric versus an adult? Okay, that is a good question. In general, for children, we think about 50 kilos, because usually when you're calculating everything per kilo, once you hit 50 kilos, you're kind of getting to that maximum dose. So the one thing that's different in DKA, well, two things to talk about. One is the insulin. So that's always based on weight. So an adult sized patient who's 100 kilos gets 10 units of insulin an hour. For fluids, we've actually increased